Welcome to my lecture on eating disorders and introduction. I'm very excited to do this for ENIGMA-U. My name is Esther Walton. I'm an assistant professor in clinical psychology at the University of Bath. For this short lecture, I will take you through a few myths about eating disorders. Then I'm going to talk about the diagnostic criteria for 3 of the most common eating disorders. Then I talk about risk factors, including genetic and non-genetic risk factors, with a short slide on treatment and further reading materials. There are many myths about eating disorders, and I focus on 3 of them. So the first myth that's out there is that eating disorders is a thing for teenage girls. So only teenage girls suffer from eating disorders. And I did a quick search on Google for images, and the only search term I put in was eating disorders, and these are the images I got back, and you can see that there's a quite heavy focus on young women. But that's wrong. Eating disorders can affect anyone at any age, of any gender identity, any socioeconomic background, and I would like to emphasize especially that men can also suffer from eating disorders, and there are quite a few number of engagement initiatives that highlight the need to allow men to come forward with eating disorders too, as well as other individuals across the age range and across socioeconomic backgrounds. The second myth is that social media is the main or sole cause for eating disorders, and that, again, especially young teenage girls who engage too much on Twitter or TikTok will develop an eating disorder. But again, that's not quite accurate. Eating disorders have many different causes, including, of course, social-cultural causes, including an appreciation of thinness that you might come across in various social media platforms. But in addition, there are also psychological causes as well as biological ones. The third myth is a misconception that eating disorders are not that severe. Again, that's completely wrong. There's often an understanding that eating disorders is a fashionable thing for teenage girls to develop, but it's completely misleading. Eating disorders are very severe mental health conditions. In fact, anorexia has the highest mortality of any psychiatric disorder other than opioid use, with very high mortality rates, and it is definitely anorexia as well as eating disorders in general, a condition that has to be taken seriously. So what do I mean when I talk about eating disorders? The 3 most common eating disorders are anorexia nervosa, bulimia nervosa, as well as binge eating disorders. There are other disorders which I will not talk about today, but please look them up, and they're also alluded to in the suggested further reading materials at the end. Anorexia nervosa is characterized by a restriction of energy intake. But importantly, this is relative to the requirements. So if you're already taking in more energy than you require and you reduce that down by just a couple of percentage points, then that would not meet the diagnostic criteria for anorexia. It's important that this restriction leads to a significant low body weight. However, this has to be considered in the context of age, sex, developmental trajectory, and physical health of the individual. So there's now a move away from very clear cutoff points in terms of BMI. It's important to note that especially for young children with eating disorders, BMI measures might not work very well, and here it's more important to look at a percentage point or percentiles, in which percentile the person finds himself or herself in relation to the reference points. Anorexia is also characterized by an intense fear of gaining weight, or alternatively persistent behavior that interferes with weight gain. Most commonly, this would be the engagement in excessive exercise. Thirdly, there's often in patients a misperception of one's own body weight and shape. Okay, and this misconception can also influence the self-worth of a person. There's often also a persistent lack of recognition of the seriousness of low body weight. There are two subtypes in anorexia, the restricting subtype and the binge eating purging subtype. Purging refers to self-induced vomiting or, for example, the use of laxatives. Bulimia nervosa is characterized by binge eating episodes. So these are episodes of eating, often within a 2-hour period, and eating an amount of food that's definitely larger than what most individuals would eat in a similar period of time or under similar circumstances. Importantly, there's also, this is accompanied by the feeling that one cannot stop eating or lost control of or how much one is eating. In relationship to this feeling of loss of control, there are then afterwards often an engagement in compensatory behaviors such as purging, fasting, or excessive exercise. Just like with anorexia, it's important that this will impact the self-evaluation of a person, and the self-evaluation is excessively influenced by one's own body weight or shape. Binge eating disorder, again, is characterized by binge eating episodes, just like before, that is causing marked distress. But importantly, in binge eating disorders, you do not observe those compensatory behaviors I mentioned on the previous slides. Who is affected? Eating disorders can affect everyone. Generally, the prevalence rates across all eating disorders are about 5% of the population, although those estimates can vary quite a bit. And while everyone can be affected, it is true that eating disorders appear more commonly in adolescence and early adulthood, especially in women between the age of 12 and 35 years. There's often high comorbidity rates with depression, anxiety, obsessive-compulsive disorder, and substance use disorder. And this co-occurrence is observed both on a phenotypic level, so you might see patients that have both a diagnosis of an eating disorder and depression, or show high symptoms of depression or depressive symptoms, but you also observe that on a genetic level. In terms of genetics, the twin-based heritability estimates for eating disorders range between 30 to 70%. Now that's a quite large range, indicating that we still do not fully understand the genetics of eating disorders. One of the latest GWASs, so genome-wide association studies for anorexia, looked in patients, over 17 or about 70,000 patients with anorexia and about 55,000 controls, and discovered a SNP-based heritability between 11 and 17%. Again, SNP-based heritability estimates are often lower than twin-based heritability estimates, but in combination, those two estimates suggest that there's a strong genetic component to eating disorders. That GWAS study not only identified 8 GWAS loci for anorexia, but importantly, they also identified genes that relate to both or indicate both psychological as well as metabolic drivers of anorexia nervosa. And that was very important to highlight that anorexia in particular is not just a mental health condition, but actually carries a metabolic component too. There were also significant genetic correlations with other psychiatric disorders, physical activity, and metabolic traits. Our understanding regarding the genetic underpinnings of bulimia nervosa and binge eating disorder is still quite weak, so there's a lot more research that needs to be done. In addition to genetic risk factors, there are also other risk factors. I included a few here, but they are this is by no means an exclusive or inclusive list or comprehensive list of risk factors, but the most commonly or most well-replicated risk factors for eating disorders include an experience of stressful life events during childhood, such as trauma, for example, interpersonal sensitivity or history of sexual abuse, especially during childhood, in addition to personality traits such as perfectionism, persistence, or engagement in physical or extensive physical activity, as well as a drive for thinness. Engaging in a diet can often be a trigger to develop an eating disorder that might bring out a genetic predisposition to the development of eating disorder by setting a trigger. In addition to that, there have been studies identifying a range of pre- and perinatal risk factors, such as prematurity, so being born too early, as well as increased parental age and maternal smoking during pregnancy. In terms of treatment, the first line of treatment is renourishment, so nutritional treatment, trying to get the person back to a more healthy weight, and at which point psychological treatment can also start in young children. That is often family-based. In addition, and especially in older children, complemented by cognitive behavioral therapy, so CBT. Eating disorders are often associated with a range of medical complications, such as heart and gastrointestinal problems, and these would often also be addressed, often pharmacologically. As of now, there's no pharmacological treatment for anorexia, but there have been treatments FDA approved for bulimia nervosa as well as binge eating disorder. Often, first line of treatment for binge eating is, for example, the use of antidepressants. And with that, I thank you very much. I put down 3 suggested reading papers. The first one is the 9 Truths About Eating Disorders. The second paper is explaining in more detail the genetics of the eating disorder. And I also encourage you to look up information materials offered by charity groups in the UK. That would, for example, be BEAT, a charity group for eating disorders. Thank you so much.